Okay. Hi, everyone. Welcome to the Tower Hamlets Trauma-informed community of practice. We have these events every month, so hopefully you now have it in your calendar. And it's just a chance to learn about different topics related to trauma-informed practice or approaches that are a bit more practical and applied in Tower Hamlets or East London. I'm one of the co-chairs of this group. My name's Angela Burns, and I'm a public health program manager in Tower Hamlets Council. And the other co-chair of the group is Patricia Potter, who is in East London Foundation Trust. So it's great to have lots of different people here today. And I'm excited about the two presentations we have because they're different, but I think that there might be some kind of themes that come across that feel relevant to both. So first, we're going to be hearing from Professor Winston Morgan, who works out of University of East London, and he's going to be presenting his research that came out of the COVID pandemic and particularly focused on understanding the perspectives of different Black communities in East London when it came to COVID vaccinations. So that will be we hear from first, and there will be time for some Q&A after that. And then second, we'll be hearing from Jennifer Rigby, who is a clinical associate in psychology at ELFT, or East London Foundation Trust, and she'll be sharing her qualitative research around the impact of trauma-informed training on staff. So I'll hand over now to Professor Morgan to share his presentation. Oh, and feel free to put any questions in the chat, and we can go through them throughout the presentation.
So I'm assuming that you can see my slide.
We can, yes.
Great. So the work that I did is based on rebuilding trust, and it was really having conversations about vaccine hesitancy and mistrust in communities described as Black in Tower Hamlets area. This is why I'm Professor of Toxicology, Equity and Inclusive Practice. The toxicology bit, I use that in conversations during COVID to explain to people how vaccines are developed and and their safety. And then the equity and inclusive practice was just about how we notice inequalities. So it just happens that my, if you like, my title and research area sort of overlapped with what was going on in COVID. So now this is where it all started. This looks really complicated, but if we just focus on the top part of it where it says males and the sort of green ones, it was just the idea that basically there were a disproportionate number of Black, particularly people who were in the first wave of COVID who were affected by deaths from COVID. This is the ONS data. And then even when you control for a variety of things like age, deprivation, housing, all these kind of things, you still had a significantly almost sort of 2 times more likely to die from COVID amongst this community. So there's something else going on, and this had consequences for society generally. And one of the things I did during the times, I did a lot of public engagement work, is I noticed, and I wrote an article in the magazine called Men's Health, and this was an illustration that someone produced where it basically showed that at the time, if you remember, if you were Black, you felt that, if you like, the COVID world was on your shoulder because you were the ones who were dying from COVID, and no one can explain why, apart from the inherent sort of the subtle suggestion, however you want to describe it, that it's something inherent in you that was this was you know, that's the reason why. There's something about being Black that made you more likely to suffer. And so despite appearing to be at greater risk from the virus, when they then developed a vaccine, we found that Black people were less likely to be vaccinated. And so we wanted to find out why. And so this is just some data that I gained from from ONS, where you can see that whereas white people of different ages were up to sort of 98, 99% taking the vaccine, Black people, depending on their age, really young Black people, for example, were far less likely to take the vaccine. And so we wanted to have conversations about that. And when you say Black, I said there are different groups, and that's why when we did our studies, I don't hope you can hear someone's doing some work outside, so it might be a bit noisy in the background, I don't know. But anyway, so the idea is Black groups are being disproportionately affected, but they weren't taking the vaccine. So how did Tower Hamlets public health team respond? They decided we should have a community participatory project to explore and deconstruct issues around trust, because we knew it was around trust. They did not trust the messaging coming from either the local authority or even the national government around why they should take the vaccine. And so we wanted to find out why at a local level. So we wanted to gain insights in local health inequalities and also insights regarding vaccine uptake. And one of the things that were really important was the messaging, the messaging and communication from the local authority. How important was that? Sorry, I'm just going to close my window, see if that helps. Okay. So before we move on, one of the key things to understand is what vaccine hesitancy is. And according to the World Health Organization, vaccine hesitancy is really the delay in acceptance or refusal of vaccination despite vaccines being available. So that's what happened. We had this new vaccine, it was available, but people weren't taking it. But I then came up with another term that I used when I was doing my presentations and community engagement things, and I call it vaccine agency. Basically, that's defined as delay in acceptance of vaccination in order to clarify concerns about the safety, effectiveness, and motivation for vaccination campaign. And that's what we were seeing. It wasn't vaccine hesitancy, it was more agency. People were just delaying, waiting to see what was happening. Is it safe? Because remember, this vaccine was developed relatively rapidly, and so people naturally had concerns. And so that's what it was about. It was more agency rather than hesitancy. Now, for the conversations, these are the methods we use. Basically, we had conversations. We went into these communities described as Black, and they were Somali, Black African, Black Caribbean primarily. And we had conversations with them. We had about 130 participants in total. And for the smaller communities, sometimes we needed interpreters for the older groups, but generally we communicated them with in English. And we always had someone from that group to co-facilitate the process. The whole thing was, if you like, a project where the participants and the researchers worked together in a collaborative way. It wasn't us as academics from the university, and I had several colleagues working with me who was just sort of dictating what was said and what the conversations were about. So let's move on to the themes that were identified. Themes identified during the conversations. There's clearly a lack of confidence and trust in the local services, and particularly the NHS. People felt neglected and unsupported. There were clear communication barriers. So what we were saying to them, they weren't receiving it in the way we wanted them to. And there was also this great dependency on faith and community leaders. So if you were a member of those communities, but you weren't part of a community group or a church group or a mosque or something like that, then you wouldn't necessarily get the communication. So that's an issue, and that's something else that the local authority will need to think about. So what I'm now going to do is basically take you through some of the things that people said in these conversations. There's a lot of information, and I've only got half an hour now, about 20 minutes, so even less than that. So I want to rush through and then sort of highlight some of the key things. So first things, these are the young Somali men, see, they're up to about 40 years old, and so born and raised in the UK. So generally, language wasn't an issue for them. And so no interpreters for Somali speaking patients. That was one of the first things they said. Even though they spoke English, they were referring to perhaps help needed by their parents. So, and first thing they said was that the vaccine was introduced as a control measure to control them as a community. Even people who had taken the vaccine could still get the virus. And so it was not a bulletproof vest, they described it. So they were saying, first of all, you're giving us this vaccine to control us, and even if when we get the vaccine, you could still get it. So these were sort of mistrust, and a lot of these things were driven by things that people heard either in their communities or on social media. There was a lot of concern about the vaccine not being vaccinated meant not being able to travel. So one of the things they thought about, this was a coercive method or a coercive approach. You wanted us to take the vaccine if you wanted to travel. So again, it wasn't something that they could do voluntarily. They had to sign up to it. So they were asking questions about what was the motivation behind the vaccination push, and everything seemed sinister. So when we had these conversations, these were the messages that we were getting from the people. And all of these are quotes that you see are things that people said, and we've written them down verbatim. So they're not our words, they are the people's words as they said them. And they highlight issues of racial discrimination, a lack of caring combined with uncertainty about the whole program. The doctors didn't try and communicate with something else, they said. There's a barrier between the community and the system. And the system could be both the local authorities as well as the NHS services provided. Okay. Beyond health, that was the other interesting thing about the young Somali group. Once we started having a conversation, they wanted to talk about other issues. So young people, they wanted to talk about not being given jobs, dropping out of education. They just didn't want to have a conversation about health, but we tried to keep it about health, but they wanted to talk about everything else. So what you can see is that these inequalities aren't in isolation. So they say, for example, young people are on the streets without doing anything productive, and even if given normal job, if they were given normal jobs, they would be able to communicate with their parents and older people from their community. And what they're saying also that they could have been able to communicate to their parents about the benefits of the vaccine if they were part of the system, but because they were outside the system, because they'd left school early, this was a big issue. Okay, so now we then had a conversation with senior Somaliland. So these are going to be sort of like over 40, but mainly these are sort of 50s, 60s, 70s, that kind of thing. In this group, they did need an interpreter. But one of the interesting things when we started this, the perception was people weren't willing to engage with the NHS and that kind of thing. But what we found with this group, they were very willing to trust services. And that's what they said. They'd always trusted their doctors and services. But they weren't, if you like, that trust wasn't reciprocated. And that was their issue. The main barriers to interacting with health services and uptake of the vaccines was access due to language barriers rather than willingness to engage. So they wanted to engage, but they weren't getting the necessary messages because of language barriers. So here we have two communities, young men versus older men. One group, they could communicate, but they were being excluded in society through school and that kind of thing. Another group, they wanted to communicate and they were willing to engage, but they didn't have the language skills necessary or the necessarily sometimes social capital to do that. So it became a bit suspicious. People began to question the efficacy of it and the purpose. So there were also these things. There was no outlets for complaints or getting explanations about the vaccine. So that's another thing about the communication. If they had concerns, who would they turn to? There was limited opportunities for in-person visits to the GPs. If you remember, we went online, and this had a number of issues. I could not afford to buy enough credit to make a telephone call and wait on the phone to speak to the GP. Eventually, the call ran out and I lost my money. So they try and call their GPs, but a lot of these people might have the type of phone contracts that didn't have unlimited text and unlimited calls, so they had to sort of hang up after a period of time. So that was an issue. They also said they felt that that if they complained too much, they could be kicked off the NHS register. So again, they were not necessarily happy, but they felt that they didn't want to complain because, again, not understanding the system, they could be kicked off. They highlighted poor attitude of health professionals. It seems that they didn't care. They were just interested in their salaries. It was a point that came. Nothing has been done for Somali communities for the past 6 years. People don't use the system anymore, even for important things such as maternity issues. They keep it in the community. So one of the things they felt from their personal experiences and talking to each other is that we're not getting the help. So what we're going to try and do is basically turn on ourselves and use community services. They didn't listen to anything. Okay, and that's the general dissatisfaction. I want to move on to the Somali women now, and these we had them in separate groups for cultural reasons. This is how they wanted to do that, and we accommodated them. And again, women were hesitant to take the vaccine, normally for health reasons, because they suspected that it could cause things like blood clots, etc. But again, like the other groups, they felt they had no choice, for example, in terms of travel. And they would say things like, educated white people were reluctant to take the vaccine, so why are we being asked to take it? And another important thing is the main channel of information was community, where information was poor or wrong. So that's the other thing. So they got the information from each other through social media, and that was giving them not necessarily the right kind of information. They did not trust the NHS. Again, this repeated issue, and they also had difficulty accessing healthcare. And one of the things that they pointed out, and it's on the next slide, you'll see is this issue around going online. So this group didn't feel that they can use the system going online. So, for example, we are not good at uploading photos, and this caused me frustration, and I therefore had to rely on my children to do it, and it is not private anymore. So you can imagine someone having a very personal medical issue having to rely on their young children or grandchildren to upload their medical issues, or take a picture or something like that, which they weren't happy with. And there are also issues about language and communication. Because we don't have time, I'm going to switch to other communities just so that we can give you a sense of what was going on. But these are the kind of things. The other thing that I should have said about the women as opposed to the men, the women, Somali women, said they placed their trust in God. So they would talk more about religion and the impact of their religion and their religious leadership, whereas the men tended not to talk about that. Okay. So the next group we looked at, looked at 2 Black African groups through churches, because that was the way we found we could get in touch with the Black African groups through churches, whereas the Somali group, they were through community groups. So this was, I suppose they're the same thing, but these were identified through churches. And the highest level is mistrust in the government. Was from this group, or they were one of the highest level, and there was selective or a lack of information and a feeling of being pushed into taking the vaccine. So again, that theme of being pushed into taking it, we were forced or coerced into taking the vaccine when the establishment was not taking it. So again, it's this idea of people being asked to take it, the ordinary people, whereas the people who were important weren't being forced to do it. Existing inequalities and other issues came into the conversation. Again, this idea that once you start talking about health, people want you to talk about everything else. So this tells us that the local authority needs to have more conversations around the other issues. Frontline workers, and remember, there are a lot of frontline workers in the NHS working, and they were also talking to them, and they were finding that whereas the frontline workers, they're either being mistreated by the NHS, or they were themselves not taking the vaccine. So this was having an impact on who took the vaccine. The other issue is not enough understanding about Black people, for example, how we speak, that kind of thing. They said, oh, how I speak, I should say, experiment. And also this idea of the vaccine being experimental. Again, that's one church. I'm going to go to the next church group, but the themes are quite similar. They didn't take African opinions into consideration, and culturally it takes a lot to change a person's opinion. So that's something else. You were told if you took the vaccine, you wouldn't get COVID. So again, that theme, that resonated with a lot of people. I'm looking at the time, so I want to finish in a few more minutes. So again, there was another African group, and again, similar kind of theme. Some participants spoke about being told to take the vaccine, being an antichrist. So again, there were religious pushback. So not only were sometimes you were finding some churches were supporting vaccine uptake, other churches were telling people, and other religious leaders were saying, don't take it, it's against God or something like that. So those things were sort of adding to the anxiety and fear and that kind of thing. A lot of Black people didn't believe the vaccine was real, and they also relied on their own immune system, or that's what they said. They relied on their own immune system, or they would use their own sort of remedies. Again, they were just using Black people again. So this idea, a lot of the time, some of the conversations, not in this, they talked about, I don't know if you remember the Tuskegee experiment and things like that, where people experimented on Black people unethically. So there are lots and lots of different issues. And we're going to move on to the last 2 groups in the next few minutes. So the African Caribbean group. Difficulty with this group was that it's quite a small group in Tower Hamlets, so we found it very difficult to find people from this group, but we did. And again, same issues, high levels of mistrust. They wanted to point out that the COVID vaccine actually highlighted other inequalities. Sorry, I am Russian, and not very happy with using Black people again. So this idea of using Black people as an experimental model for the vaccine to see if it works and then give it to other people. There were questions about the impact on fertility, again, another big issue that kept coming up. And this group also had many international connections. So they were getting their information not just from the UK, but they would talk to colleagues, some family and friends in the Caribbean as well as in North America. And this also sort of impacted how they responded. And this theme of that doesn't affect Black people, that was about the vaccine, especially early on. Not the vaccine, sorry, the virus. It doesn't affect Black people. If people were dying, it wasn't nothing to do with this COVID, that kind of thing. And also, again, this use of natural remedies or relying on their immune system was also an important thing. There are lots of WhatsApp messages. For example, the heat keeps the vaccine away, or the virus away, I should say. So again, that was the kind of theme that people had. Reasons they gave for not taking the vaccine. Remember, as I said, there was a big inequality or big difference in terms of how many Black people took the vaccine. Our skin makes us immune, all those kind of things. Then he talked about things like microwave effect, etc. Finally, we happen to just have a group of Bangladeshi women who happen to be in one of the centres. So we also did a session with them. And again, a bit like the Somali women, they were more, they sort of put their trust in God and what the religious leaders were saying would drive whether they took the vaccine or not. But they were also concerned about the health issues. So that was, I suppose, stereotypical, but women more concerned about the health issues around the vaccine. But they also, this one was quite interesting. I myself was worried about vaccination. My father died of vaccination. People who are killed were forced to take the vaccine. So this idea, if you take the vaccine and it's the vaccine that kills you rather than the virus, was a theme that came up in that session. They were feared about blood clots, as I said. That was something that was quite big. Talked about problems with periods and heart problems. So they, as I said, this group talked about more medical things rather than anything else that was driving the whole thing. And that's those. Hopefully, I've given you a sense of how the whole thing went on. So generally, in terms of conclusions and recommendations, okay. What we found was that it was an opportunity for communities described as Black to share their concerns around health, but other things. And all groups wanted to talk about other issues, not just health inequalities or not just the vaccine inequalities around vaccine and death from COVID. They wanted to really communicate. And these are the recommendations. I'm not going to read them out, but they're just bullet points. But they're all really around getting people in the local authority to really get in and understand their communities. It's about having better communication in terms of different languages, having more people who understand these communities. So setting up working groups, for example, with stakeholders in the communities. There were some limitations. It says only groups with direct or indirect contact with the local authority we spoke to. So for example, if you went to a church that the local authority knew about, or if you went to a community centre, which the local authority knew about, would you be able to be part of this conversation? So that's it. You can see the number of people who are involved in collecting this information. So thank you very much. Sorry it's a bit rushed, but I hope I've given you a sense of what people were thinking and doing at that time around the vaccine. As I said, I'm going to share the full, so you can have the slide, and also the local authority also has the full report so you can read that. But hopefully that gives you a sense of what was going on. So thank you very much.
Thank you so much, Winston, and apologies for making you go so quick, because I know that there's a lot of rich information in what you and the team looked at. Welcome questions from the group. I guess just reflecting on what you've said, it really relates quite strongly to a few of the different I guess, principles of trauma-informed approaches. So obviously you talked about trust a lot, and there are different elements that you brought up that relate to why people have mistrust with different services, even when we have the best intentions of trying to improve someone's life one way or another. But also the point that you made around the need for more choice and collaboration. And I think too, that people aren't approaching a service in isolation. They have many different interactions with institutions and services. And I think that that's quite a lot of pressure for individual professionals to have to manage. So it's something that we have to think about kind of more collectively on how we address that and support, because it's not something that an individual nurse or pharmacist can really take on. But yeah, thank you.
Although you can't, sorry to say, but you can actually build local trust by having those relationships as well. So people may come in with a sort of like a preformed view about how they're going to be treated. But if you can quickly, as an individual professional, in sort of establish kind of trust, and I think people will actually listen to you.
Definitely welcome this an open approach. Are there any questions from group? You can, I think we're small enough that you can probably just step in and speak. Salar?
Hi, I'm Salar, social worker from the
Hi, Salar.
team. Yeah, thank you for that presentation. It was very interesting, and I think for myself, I've probably buried a lot of what happened in the COVID period as a way of sort of coping with the post, and just listened to actually brought back some of the memories and the anxieties and all that stuff. And I remember I've grew up in town and speaking to a lot of people in the community. I think you touched on a lot of stuff. Couple of things was a lot of young people had not maybe seen GPs for years. You know, they're fit, they're healthy, they didn't want to take the vaccine. What is, you know, it's mainly affecting the older people. Why should I take it? And I think that another thing was what you said about people being like guinea pigs, if you like, because it was rushed, the vaccine. And when you hear like a vaccine takes 15 years by the time it gets tested and out on the market, and this was rushed through in less than a year probably. So there was that sort of mistrust. But I think a lot of learning came from your study, I suppose, how that learning and how that sort of now comes into practice, if you like, to engage those communities and build those relations where there's mistrust. And I suppose on a local level and a national level, we've just gone back to sort of like COVID's over, right? We go back to how we were before, or, you know, what is being done, that sort of thing. I want to know a bit more about that.
Well, I suppose that's the danger. That's why I suppose this kind of study is important, so that we don't go back. Because although you say people noticed the vaccine was developed really quickly, but if you like, some communities took the vaccine regardless of it being developed quickly because the professionals and the government said this is safe and you can take it. Whereas other communities, because of their personal experiences or collective experiences, decided, right, no, I don't really trust this, despite the fact that every day the chief medical officer and the chief scientific officer was encouraging them to do it. They still didn't trust that because of their own personal experiences. So that's something that we have to really understand and explore, and how we can change that, so that just as 98% of white British people were taking it, over 80, for example, why was that down to perhaps about 70% of black people taking it at that age? But it's a good point you've made. Sorry.
Actually, I commented in the chat because I know Cyril's here and has been leading on a pretty significant program of work on this topic specific to public health in Tower Hamlets. But I wonder, Cyril, if it's okay, rather than having you speak just because I'm conscious of time, would you mind if I circulate some of your materials after the meeting? Cool. Thank you. Let's go to Muslima and then Patricia.
Thank you. Thank you, Morgan, for the presentation. So I thought it was really interesting how the way that we talked about immunity and vaccination was really done, you know, out of fear and necessity, and like the question of freedom, like on your slides, was really popped up a lot. Like your right to work, your right to go outside is compromised by this vaccine, and it was almost looked at as, you know, I think as a citizen, it looks like the vaccine's being almost like a tool of control. And I think when we're talking about mistrust, you know, from a national level, there's a lot of change, and it's, for example, like the messaging around the vaccine was really unclear. It was changing, you know, each month, and I think that people were seeing that. But what I thought was that really stood out was how we were discussing immunity. And so how do we navigate that space where the way that immunity works is by having, you know, everyone be on board and taking the vaccine, but then also how do you get that buy-in when it looks like on a national level that the way that we're doing it is by not forcing people, but really shaming people into taking a vaccine. So in your opinion, and maybe considering how we keep our responses trauma-informed, but how do we create a space for people to express, you know, their mistrust for the system and their right to understand the vaccine and make a choice on that, but also respect that for immunity to work, everyone has to be vaccinated, or nearly everyone. Yeah.
Yeah, well, I think the thing about vaccines is that so they're a kind of unique type of medicine where you're giving someone either perhaps a living it's a biological medicine, and people always have concerns about that. And you also get it when you yourself aren't ill. You're trying to prevent or protect a community, and it does require a different type of conversation. If you don't, I mean, as I said earlier, for some communities, because the authorities said take it, they took it. They didn't really, they're not really asking any questions. Whereas other communities, they need to have that information, and that information needs to come from people who we called at the time, because I did a lot of this work, trusted messengers, and that people know and they can talk to. And so one of the ways it worked for me, I did a lot of work with Newham, is I would be going back every 2 weeks to their public health team, and that we had these community conversations. And so they would see me regularly, and they know who I am and where I am. And so I wasn't someone who popped in and said, right, take this vaccine, it's safe, and then go away and never see me again. I came back regularly, and I answered questions. If they got something in the next 2 weeks, if you like, they bring it back to me and say, Winston, you said this, and I heard this. And so they developed a conversation. So that's one way I think of getting that trust in that kind of situation. I don't know if I've answered your question, but yeah.
I think you did. Thank you.
Thank you.
Over to Patricia.
Thank you. I don't think I've got a question in this, but really interesting research. What I want to say touches on what Lucy was saying, and a bit more, that I think it's a really good example of collective trauma, how people kind of have stories that families and communities tell about what's happened and what's gone before affect us in the present day. But I think the other thing that's really striking to me, and it's sadly not new, is that this lack of trust and lack of mutuality predates the vaccine and COVID. That this is the, you know, this kind of reference to things that have gone before. Is that something that kind of came out, and again, sort of thinking about how we can not, obviously focusing on the vaccine is really important, but the wider story that your research tells about relationships and trust between our communities and our organizations.
Yeah, definitely. That, you know, people kept saying, you know, that you know, it's a long term. It isn't just around the vaccine, and that's what, in a sense, because they didn't have the trust COVID, they're not going to suddenly have it in this heightened situation. The other thing I should have said around the trauma, if you like, is there were people who took the vaccine who came to these, but they were still worried because of the messages. And one of the things we had to do is reassure them, yeah, you've taken it. Did I make a mistake, if you like, in taking it? People were really concerned. So it wasn't only having information for people who didn't take the vaccine. You also needed to reassure people who did it, because they were really sort of, some people were really stressed. They were worried and counting off the days. When is something going to happen to me? And so one of the things I had sort of explained to people about with this type of a medicine, if you like, if you're going to get any adverse effects, which is what people worry about, it would be within sort of like 2 or 3 weeks, if anything, and then after that probably nothing would happen. But those kind of conversations. But yeah, definitely we know people are talking about their examples of previous exclusions, and this idea of going from, if you like, from being back of the queue to being at the front of the queue, using sort of Barack Obama kind of terminology, but you know what I mean. So that kind of thing. Why were we suddenly at the front of the queue when for other, whether it's the flu or the whatever it is, other kind of vaccination things, no one was really that interested in having us do it.
Great, thank you. I'm sure there will be other reflections that cross people's minds across the day, but just wanted to say thank you for your presentation and for sharing your research. We'll circulate Winston's slides after with the rest of the materials.
Yeah, I'll stay to the end if anyone thinks of anything else, and then.
Thank you. Great. So we are now going to switch gears a little bit, and we're going to hear actually more from the perspective of staff. But I think there may be some things that come up that resonate still with the first presentation too. So I'm going to hand over to Jennifer if you want to start sharing your slides. Thank you. Hello, everyone. Thank you, Winston, for that really interesting presentation. As Angela said, we'll be talking about some research that I've done for quite a different topic, but yeah, hopefully there's some common themes. So I did a service-related research project on the impact of trauma-informed care training that I was delivering to staff in ELFT. And I'm a clinical associate in psychology, and I work in the Tower Hamlets complex emotional needs and complex trauma team. And yeah. So a little bit about the training. It was a one-day online training about trauma-informed care, very much like the beginner basics. And it was delivered 3 times between April and September last year. It was open to all staff in ELFT, and it was designed and delivered by CAPS in training and trauma leads across Newham, Tower Hamlets and City and Hackney. So just a little bit about the literature sort of in support of trauma-informed care training. The literature suggests that training can lead to behaviour changes, with a greater increase in inquiring about trauma, and also training can shift attitudes and confidence towards trauma-informed care. Similarly, this other study found that attitudes towards trauma can improve significantly following training, and that participants change their behaviours in result of the training. But things like time constraints, lack of confidence, and limited opportunities to practice were some barriers that came despite the positive changes. Some other barriers that literature suggests are things like time constraints, insufficient support, underfunding, austerity, staff shortages, leading to stressful work environments and overworked staff, and sort of top-down changes coupled with like numerous new initiatives, policy shifts, leading to confusion and exhaustion. Similarly, sort of low morale and high staff turnover was suggested to reduce the potential long-term meaningful change that trauma-informed care training can bring about. So that was sort of the starting point, and I wanted to look into the impact of the training that we were delivering to see whether it was having any impact on staff. And so the aim was, to investigate the impact of the training, to evaluate whether it was leading to actions to integrate trauma-informed care into services. And specifically, the impact I was looking at was sort of what actions have been taken since the training, when were they implemented, and why these changes, what barriers were there to taking actions or to implementing trauma-informed care, what resources were needed, and sort of people's reflections overall on the training as well. The method I used was qualitative, so I did semi-structured interviews, approximately 10 to 15 minutes. The sample I was aiming for was 6 to 8 people who had participated in the training. This number was picked because of the time frame that I had to do the project, and I was doing it alone. The analysis method was thematic analysis, and no ethical approval was deemed required by the trust, but informed consent was obtained, and there was no compensation or reward offered for participating. So I managed to get 7 participants, and the mean interview time was about 15 minutes and 30 seconds. In the table there, you can see sort of the breakdown of demographics, and mostly it was psychological staff and nursing staff, but I got quite a good spread across the boroughs. So yeah, it was sort of similar demographics to the people who participated in the training. So it was quite a representative sample compared to the people who participated in the training, which was good. Right, so in terms of the themes that came up, so just to explain this picture. So you've got the three main themes at the top that came up. So learning, barriers, and attitudes. And then below them in the square boxes, you've got sort of the sub-themes. And then below that in the sort of rounded boxes, you've got the sub-themes within the sub-themes. So it looks a little bit confusing, but I'll be talking just mainly about the three broad themes of learning, barriers, and attitudes. So in terms of learning, one of the biggest things that came up was continued confusion between trauma-informed care and trauma treatment or trauma therapy. So in this quote, I think it exemplifies it quite nicely, where the participant continuously confused trauma-informed care with trauma treatment. And despite expressing that they understood what trauma-informed care was, continued to mix them up. So for example, here I was asking about like, what ways do you practice trauma-informed care? And then they started talking about, well, delivering trauma interventions. And then I clarified what trauma-informed care was and asked about barriers. And they said that referral onto psychology was the biggest barrier to access treatment, to access trauma treatment, not to implement trauma-informed care. So yeah, that was quite a big one. Another important aspect of the learning theme that came up was people struggling to remember the content. This was important because we only did one training day. There was no follow-up, and slides and stuff weren't provided because we didn't want those slides to be shared with other people, and then for people to say, oh, well, I've done trauma-informed training having just read the slides, and say, oh, I'm now trauma-informed. You know, being trauma-informed and it's more than just reading slides. So part of that was that people couldn't really remember much about the training or showed gaps in their memory. So someone here said, I can't remember the 5 Fs or the 4 Rs. Someone highlighting, like, unless there's some kind of follow-up, then it's hard to hold on to the training. People saying, you know, I always forget stuff without being able to look over it. And in terms of barriers, so the lack of knowledge of how to implement what was learned was quite a key barrier. So participants identified that resources and practical examples relevant to their job settings or continued support would help them implement it more. So we've got some quotes here, people saying, like, yeah, if there was a resource provided, like principle kind of thing, something that's practical that you can hold on to. Participant number 2 here had a good quote, well, said, you know, how do we make it practical? How do we apply it in our team? It felt quite abstract. It's got to be kind of real and tangible examples. And someone saying, you know, as much written information as I can get, you know, would be helpful. A visual experience of what that might look like and how staff might respond in a trauma-informed way would be great. So lots of people talking about, yeah, how the training was good, but perhaps a bit too abstract and weren't sure how to apply it in practice. Another key barrier was that participants felt there was a lack of broader awareness in teams and in the trust about trauma-informed care, and how there was sort of a need for a cultural and structural shift towards trauma-informed care. Managers or wider teams were identified as barriers if they were not aware of trauma-informed care, and NHS policies not in line with trauma-informed practices as well, similarly, were considered barriers. So, for example, in these quotes, we've got the policies, I suppose, were barriers. People not having an awareness would be a barrier, particularly if you have a supervisor that doesn't have an awareness. It's a bit more difficult to implement. And yes, the more people who are aware, the easier it would be to implement trauma-informed care. So that one was quite a big one and links strongly to attitudes. So despite there being generally positive attitudes about trauma-informed care and the training overall, there was a real strong sense of powerlessness that was sort of linked to these barriers, particularly the systemic barriers like money, staffing, time, and the sort of lack of cultural or structural sort of viewpoint of trauma-informed viewpoint. And that made it difficult to implement changes or be motivated to make changes. So we got people questioning, for example, how much of trauma-informed care is actually possible. We try to do our best, but sometimes we just can't because there are things that are out of our control. I think it's the pressure within the system. So staffing levels create a pressure, then that creates stress for the staff, and then the staff member, trauma-informed care becomes secondary to the stress and the workload. And there are all these policies that come on into staff, but it's coming all from above, and they're not really seeing how much time it takes to do these things. So yeah, a real sort of chorus of people saying that we'd like to make changes, but it feels a little bit out of our hands. So in terms of strengths and limitations of the study, although it was a small sample size, I got quite sort of both ends of the spectrum in terms of attitudes and uptake. I got one person who is really like not interested in taking up trauma-informed care. Yeah, and then I got someone else who's super into it, really promoting it, really championing it within their team, and then sort of the range of people within those two ends of the scale. And also I did find that my results aligned with the other literature, which was great, was good, was affirming. In terms of limitations, so there was no reward for participation, which means obviously the people who participated volunteered, which then made me wonder, perhaps these people are more likely to engage with things anyway. So how generalizable are the conclusions about their willingness to engage or implement things? But also qualitative research is considered to have limited generalizability anyway, because it's so specific. And so these results are unlikely to be relevant to other trauma-informed care training programs, other trusts, healthcare settings, that kind of thing. So it's very specific to the training and the trust and that kind of thing. But conclusions-wise, so learning about trauma-informed care is instrumental into whether the training was impactful or not, because if people couldn't remember what they were learning, it's really hard to implement anything. And there was also, that lasting confusion between the difference between trauma-informed care and trauma therapy, making it then difficult to implement trauma-informed care. And despite general positive attitudes towards trauma-informed care, there were barriers preventing implementation, creating this sense of powerlessness. And those key barriers that were identified were a lack of trauma-informed care culture and awareness, and then like practical barriers like time to practice trauma-informed care, to go on to trainings, staffing. So as that other example said about low staffing creating stressful work environments, which then makes it difficult to try new things or have the space and time to think from a different perspective than they're used to. And also, yes, knowledge. So without knowledge of what to do and how to do it, that's impossible to implement something. So yes, that was it. Bit of a speed round through the research. Does anyone have any questions?
Thank you. That's great and really well timed. I'm impressed that you covered everything so quickly. And just to, I guess, reaffirm, very similar conclusions from the evaluation of the training that we've previously provided and delivered across the borough. So while it may not be generalizable from a qualitative research appraisal perspective, I think common themes definitely come up.
Yeah.
As far as culture and powerlessness. Questions from the group or reflections from your own participation in training previously? Go ahead, Lucy.
It's not really a question, but it is it's a reflection because so we've recently done the trauma-informed train the trainer in adult social care. Sorry, I should have said I'm from adult social care. So there's a group of us who are going to be delivering the trauma-informed practice training, but this is a common the kind of organizational culture thing is a common thing that comes up. And yeah, just I don't know whether we are doing anything to kind of get around that. Because we can train frontline practitioners, but if we're not training everybody in the organisation, then we're always going to come up against that barrier, aren't we? That people are working within systems that don't fit with what we're training them. So yeah, it's more of a reflection. I'm not expecting everybody to answer that.
Yeah, no, absolutely. And it was something that we were reflecting on and considering as part of the training. You know, we were monitoring who was attending and noticing it was mostly psychological staff or nursing staff. And despite it being open to all staff across the trust and trying to encourage, you know, managers, people not necessarily client-facing work, trying to emphasize the importance of it across every, you know, element of the work that we do. Yeah, it was it's difficult to get that engagement, I suppose. Yeah, I don't have the answer how to fix it, but yeah.
I think it does speak to some of the barriers you highlighted around time and energy. Patricia, did you want to come in?
Thank you, and thank you for presenting that research. It was really helpful, and hopefully it was helpful for you in your training too. I think it's kind of reassuring. Anyone who knows me knows that this is a bit of one of my hotspots. That doing training with both without follow-up and also taking people out of their day job to train on something which is effectively around a culture. It's not about particular techniques that you apply individual to individuals. So it's in some ways it's reassuring that actually your results support that. I think that there is something about you know, so what do we do with this knowledge now? And I think that's conversations that we will be having, and already I know that Karina and the other leads are thinking about how to do that by training whole teams and things, and having a sort of follow-up project, and that might go some way to it. I think the other bit about the kind of culture is understanding what we mean by culture and how we do things. And you know, culture is created by individuals in terms of their behaviour, their attitude, how they are with each other and how they talk. So it's an important building block that people understand what difference it will make to them and to the people that we're serving, but also that they're doing it in a wider context where they're having conversations with people who have a similar understanding. And I do think there is a question about training the kind of most junior people with the least power, who then have to go back into a system that might not be trauma-informed. I think is something we need to take a good look at. That is that conscionable, really, or are we inadvertently causing harm? So I don't know if you do have any thoughts about how to do things differently going forward. So that's something you've been mulling around.
Yeah, I completely agree with your reflections. I think there's there's a lot to be said about like defining what is culture, and that's something that I didn't have time to do within this piece of work. But I suppose to draw on the examples that I received from my participants, you know, I had someone who was super motivated after the training, really engaged with it, went back to their team, told them all about it, you know, was really well received by their managers. And so when I did the interview, the participant was saying how grateful they were that the manager was so accommodating and really willing to take that on board, and the team were really willing to like listen to this training and stuff that he'd done. And I think that's what other people perhaps felt that they weren't getting when they went back to their teams, and they were like, oh, I went on this training, and people not having time to have those conversations with the people and to sort of diffuse and spread the learning and be supported to make changes that they want to make because of the things that they've learned. Yeah, I don't know if that really answered your question, but
Thank you. I'm conscious of time, but I do want to get to the other hand. So I'll be around for the next 10 minutes anyway. And if Jennifer, if you want to stay around, if you have time. John, do you want to ask a question?
It's more of a reflection, actually, because I've been working on a piece of work with THT around co-production, and I'm about to kind of launch it on the system in terms of kind of encouraging people to do more co-production. And one of the issues that's come up is the issue of time and capacity, which is kind of interesting to see that you're picking up these issues as well. I mean, in terms of the way I plan to resolve it, I tend to put it back to the senior leadership about how they're going to create the time and capacity for people to do this piece of work, because I think it's all great, you know, I can produce co-production pieces of toolkits that people can use, but unless they have the time and capacity to do that, they won't be able to do it. So, and I think, you know, it sounds like you're struggling with the same struggle. You know, we'll do the frontline staff, but we won't change the culture or the organisation we're operating in or the way we do things. So what I'm going to be doing with co-production, I'm going to be putting it back to the senior leadership, saying you need to create the capacity, and you need to change your programs, and you need to work with staff in a very kind of co-productive way to actually make sure this is implemented. And I think the same thing is true of this trauma-informed care. I think it's very important that we do this, but unless we have senior leadership creating the space for us to do that, we won't be able to implement it at any point. So I think exceptionally good work from both what Jennifer just said and also what Winston said. But I do think we need to put it back to our senior leadership about saying you need to create the environment that we can actually implement these pieces of work. I hope that's useful.
Thanks.
Yeah,
Jennifer, I can share your presentation across to THT because they'll be revisiting it. Thanks,
Great.
John. It's a really helpful and clear recommendation. Carol, over to you.
Yeah, hi. I cover the supported living accommodation services and our day centres. And when I arrived at Tower Hamlets about a year ago, I really did think that trauma-informed practice should be incorporated into our service specifications, so we're able to show the level of care and attention that we expect from our staff teams in terms of delivery. So not, like service providers, from the service providers angle. And I do think it is a characteristic as well. So when you talk about culture, I do think that within our services, we can develop a culture. You can have an organisational culture, but within each service has a culture. I think we do have to start with managers. I do think that it is it's necessary for our managers to have a trauma-informed approach to their staff that then, piggybacks into the service that they are delivering. We're supporting people all along the line. So from managers to their staff to service users, it's important that everybody is treated with that care in mind. I think that when we separate the trauma-informed practice from the activity, there seems to be kind of like something's missing. It should just be inherent, I think. But I do think that it's something that you can develop within your team. But yeah, I just think that sometimes we talk about it as though it's something that people have to learn. I think you can come with it, you can learn about different cultures, but there's definitely sort of a disconnect when we're discussing it, because again, in terms of monitoring services, I think that for us as commissioners, we should be able to go into a service and see trauma-informed care in practice. And often when we don't see it, we don't label it and say this is what's missing. So I think in terms of, you know, everybody getting clued up and understanding the approach is so important. And I don't think it's something that's learned overnight, but I do think it's also a characteristic that can be approached at the recruitment stage as well. So, you know, there's a lot to say about it, but yeah, I think it's a great target. But I do think that, you know, people's nature should include or should incorporate that care and empathy and understanding of experiences within our communities, so that we can then have that understanding and show that, you know, there's no separateness to this. Yeah, it's very hard for me to put it into words, but yeah, I think this has been really interesting, and your study's been really interesting as well. Thanks.
Thank you.
Thanks, Carol. Well said. And then last but not least, I can't see your name. Shauna.
Sorry.
There you go.
Yeah,
Yes,
sorry. I'll be very quick. I'll try and be very quick. Yeah, really, it links a lot to what John and Carol have just said. But when I did the training, I had exactly, I remember during the training thinking, how does this relate to, for example, a district nurse who is trying to work in a trauma-informed way, but actually knows they have to go to the next patient, and that everything will collapse in terms of their schedule for the day if they do adhere to the approach. So yes, reiterating really what John and Carol have said, it has to be something that's taken up through commissioning to actually be able to have that capacity within services. But I mean, what we do as a small team is we do discovery interviews with people, and so we're constantly triggering because we're asking people to relive things that have happened to them that didn't always go well. So I feel really conscious of we need to embed it totally into what we do, and we want refreshers. And I noticed that the last thing that I attended last month, a lot of the resources were only available to ELFT people. So that, you know, all the things I wanted to refresh myself on, I couldn't. So that's just a comment really to say I echo a lot of your findings. But yeah, I mean, we really want to embrace it. In fact, I'm fighting for reflective sessions for our team and for other people like the social prescribers who are also, you know, doing a lot of tick stuff as well. So anyway, just thanks.
Thank you, Shauna. It's a great way to end. I will remind myself to include the resources that are open to everyone in the email after. So I'll just make that a note so that hopefully you'll find something that's useful and applicable to the people you work with. On that note, thank you, Jennifer, for your presentation. Thanks again for Winston. I think really like bringing in the kind of different ends of the system and how it's difficult for all of us really. But some really good points made. Thank you. Next month, I'll send out the information for next month, but we'll be focusing actually on trauma-informed emergency response, which may not seem like it's relevant to everyone, but it's actually everyone's role. So look out for more information about that. And yeah, thank you for coming. Hope you have a good afternoon and go eat some lunch. Take care, everyone.
Bye.
Bye.
Cheers. Bye.